Welcome, and thank you so much for coming here. I'm so happy that we're going to be in conversation this evening. I do these webinars because I want to connect with my SLP team around the world. I know we have some people here today from Canada and from the United States, so that's amazing. Thank you all for joining. I'll get started quickly. For a lot of you, you've seen me or you've gone to the website, so you've had a bit of an idea of who I am. So I'll go quickly over that. But let's just jump right into it. Okay. So it is recorded. I will share my screen in a second. I open the chat. If you ever want to have a little bit of questions, please go ahead. I will look at the chat towards the end of our presentation, but please feel free to just bring in questions and I'll be happy to answer afterwards, okay? Okay, so let me share my screen. Okay, if somebody can put in the chat, if they can see the slide properly, that would be great before I get started. Yay or nay or whatever. See a message. Amazing, perfect. Okay, so I'm addressing a lot of different people here. We have speech language pathologists, we have SLPAs and CDAs. SLPAs are SLP assistants, and CDAs are communicative disorder assistants, and they are in Canada. But SLPAs and CDAs is the same role, just that in Canada we call them mostly CDAs, and in the States and other places we call them SLPAs. So I am here for everyone. I really want to connect with students. That's really the niche that I want to talk to today, or aspiring clinicians, people who want to get into the field. This is for you. I realize that there's a lot of students sometimes having different experiences and then in different settings, and then they go for interviews in different settings that they don't know how to adjust. So that's why I'm here. It's really rooted in 25 years of experience that I know how to navigate the system. I'm happy to share with you. So I'm going to look at our roles across the clinical settings. And I always put on my slides. I always put on my slides a butterfly because you guys know about the butterfly effect. And that means that a little something happened in one part of the world and it has a humongous effect in the other part of the world. So a butterfly flapped their wings once and it created a tornado in another country. What this analogy for me here is just to say that the little time that we spent together today, I hope that it has an impact in your career later on, that you've had a really good understanding of the roles and wherever you can work. And this is the beauty of our role. We can work in so many different places and reinvent ourselves, but continue to have a common thread in the background. So this is why we're here. Oh, it's not changing. Okay, there you go. I always like to put this slides because we do a lot. We do so many things. And you may start in one area of your career, or you may be in one area in your placements, and then it goes on and on and on. So I just want to reconnect with the fact that we are special people. When you're in a speech team, we help people with so many different things. I just want you to get a little bit of a glimpse of what we do. Okay, so what we'll do quickly today, I'm really going quickly here because I want to get into the meat of this presentation and have time for questions. Soledad, who? For some of you, like, oh, okay, who are you? Who are you? Just want to say a little bit about me and why I'm here. Our objectives for today, and we'll go through all the clinical settings where we work, mostly hospital settings, less in the education system, in schools. I just want to really focus in a hospital healthcare because this is where there's so much variety. And then what's next for you? We're here to learn, we're here to gather information, but what does it mean for you after that, right? And then I'll tell you more about what's next for Differently with Soul, which is my company. And we'll leave some time for question and period. Okay, who am I? Soul. I call myself Soul, easier for most people. I've been an SLP for a long time, and I learned through challenges. And I'm here today because I don't want you to suffer. I don't want you to take 10 years to finally get the groove on. I want you to do it from the beginning because I realize that this is where you find job fulfillment. If it's hard, you want to get out of it. But if you find it fulfilling, you want to stay in it. So I want you to find job fulfillment right away. I want you to practice with ease, with compassion, and a lot of expertise right away. My roles, I have way too many, guys. I'm everywhere. I work with kids, I work with adults, I work in the community, I have a private business, I work in acute care, I work in rehab. I just got called again to go to a long-term care facility this weekend. I work everywhere. But that gives me a great lens and a unique experience that I'm bringing for you today. Okay. So the reason why I found it differently with Soul, my company where I offer services for speech therapy, but also mostly coaching, is because I have a passion to share and pay forward all the help that I had so far. And I really want to find it. I wanted to have a channel to do that with you. So this is why we're here today. What I really hope that you can get from this webinar today is that providing the right care at the right time, tailoring our role to different settings and I'll say settings, but I will also say population, because if you're in the States or if you're somewhere else in the world, or if you're in Canada, we may label the different settings differently. But so I'll focus more on the population that we're servicing. The title of where they reside or where we provide care may change. So let me focus a little bit more on the population that we serve and the population that we provide care for. But you'll soon realize that providing the right care at the right time is essential. And why is it so good? Why does it matter? Is because better client outcome means greater fulfillment. You're going to understand that the way to do a good job is to be fulfilled. Like sometimes we say we have to do a good job to be fulfilled. We have to be fulfilled to be really what's going to keep you in this field is if you're fulfilled in your job. So I really hope that getting this information today will make you say, oh, okay, I know how I have to be in this setting, or if I apply in this type of job for this population, I see what I have to bring on to my interview or what I have to do, right? So this is the goal. Okay, let's get started. So here are some of the settings that we'll be talking about. There's about 8, and they're very loose, but hopefully we can really understand the different way that we can provide care in each settings. Acute care, emergency hospital, really is the first point of healthcare. You have a problem, you go to the emergency hospital to see what's going on. This is where most people go where they're unstable. It could be mentally, it could be physiologically, it could be progressively. Something's wrong, you need help. This is where you go. When we have, this is where people are like, well, the parents or the caregivers will be, are they okay? Are they going to live? Are they going to be back like before? So lots of questions about stability. And you'll soon see that your patients are nervous, stressed, the families are nervous, stressed. And sometimes you got to take this in consideration in your care. You can't just come in and say, okay, I'm here for a swallowing assessment and leave. You got to understand that they have it's anxiety provoking because they don't know what's going on. That's why they came here. So we have to support the fact they don't know what's going on at that level. Sometimes we do screening, sometimes it's quick. Some different disease have different pathways. For example, stroke, very well researched pathway and how long they need to be in the hospital, when we need to assess them, and when they need to go to the next level. So sometimes you just got to follow the pathway that's there. But most of the time for us, it's finding if there's a diagnosis, if there's a problem, what can we do to fix it? I put 2 slides here because we do a big job in acute care because it's going to set the precedence for everywhere else in our practice. And this is where we do a lot of things differently. And things change on a daily basis. And what really drives your day as a speech therapist or a SLPA or a CDA in an acute care is the caseload. The people coming through discharge, emerge. So every day you can come to a new set of people. And so you got to make an impact quickly. So you don't have time to build a relationship with the client. You build it right away. The first meeting, you're on, you are their best friend, you're their mother, their sister, their cousin. You want to make sure that they feel comfortable with you right away. It's really a place where, because things can change quickly, you got to chart right away. I'm just talking a little bit about charting, although I will have a whole webinar on documentation. This is where you want to chart right away. As soon as you see the client, the patient, right away you write it. Why? Because it changes so quickly. People can get better, people can get worse. And so you want to do point of care charting. And really, as soon as you come in, the way the hospitals, most acute care hospitals are set up, is the minute you come in, we're trying to see what can we do for you to leave. So it's all based on discharge. But really, it's a good system because we want to know they came here for a problem. Let's fix the problem. How can they go somewhere else to either continue or make them stable? So it's all focused. Every day we have rounds on every patient in the hospital, and we're trying to figure out how can they leave? What do they need to leave, right? It sounds rushed, it sounds insensitive, but trust me, it helps move the people around. It helps make sure that we do the right care and they do the essential to make sure that they get better. Now, our roles in acute care. I put some things here, on some of the slides. It's not very common in a lot of hospitals to have CDAs or SLPAs, so it's a role that's emerging. I wish I had it at my hospital. I'm really rooting for it, but I just wanted to show you how this team can work together. So really, the SLP, it's about prioritizing your caseload. Every day things change, the patients get better, worse, new patients come, patients leave. So you're always triaging. It's a lot of caseload management, and it's becoming a skill that you have to have in this world. It's a lot of assessments. You want to know if there's a problem or not. You want to know if the reason they came in here will impact their swallowing and their communication or not. So lots of assessment, lots of education. And in the middle of that, you plan your discharge. So what can I do right now? Where else are they going to go? Where else are they going to go after? Are they going home? Are they going to outpatient rehab? Are they going to inpatient rehab? Or are they going to get different type of care, right? So you have to decide on what do they need. This is where we do a lot of instrumental swallowing assessments. For those who are more familiar, it's a VFSS, it's the fees, it's some ways that we assess swallowing with a lot of machinery or equipment, and it's often in acute care that we pull out the big guns to see what the problem is. And really, if the definition of the role of a CDA and a SLPA is really to assist the SLP in some of their responsibilities. And so we do swallowing assessment. The CDA, the SLPA can also help up with the signage at bedside. Once we figure out a diet, we can put the diet above the bed so everybody knows, the nurse, the patient, the family know what diet they're on. They can do a lot of meal observations. We do a lot, 75%, if not 99% of our role is to look at swallowing. So the SLPA CDA can help out with meal observation. Super valuable in creating communication boards. If people cannot talk at the right time or while they're in acute care, it's nice to develop a little bit of a aid to be able to communicate with staff and family. And CDAs and SLPAs have so much specialty in that. There would be they have a key role in developing these tools for communication. Also, if we're doing a very comprehensive assessment, it'd be nice. It's also great to have somebody with you to take some notes along the way and have two heads to kind of think about things as well. And also a new role that's emerging is that if we are doing some instrumental swallowing assessment, they can help us prep for these assessments, help the patient, help us set up the room, and really make sure that the flow of patients goes quickly. So it's such a great adjunct to have. So it's an emerging role in acute care hospital, but I'm really rooting to have it everywhere because it would be such a complete team, right? Let's move on. Like another place where people can be when they leave an acute care hospital, people always think that you have to be 100% back to normal when you leave the hospital. Absolutely not. The acute care hospital looks at your body being stable. So no fever, no oxygen, your blood pressure is good, Every diabetes is taken care of, there's no more blood, no more ulcers, surgery's done. But then you can get better somewhere else. So that's always the goal that we're trying to do. Where can you go afterwards? And so there's inpatient rehabs. There's so many different types of places where you can go and have more services. It could be focused on stroke, it could be focused on cardiac, it could be focused on geriatric, it could be focused on breathing. So there's so many different types of rehab, and I urge you to be familiar in your region to know what type of rehab are available around you. And in rehab, all of a sudden, once people catch their breath and say, okay, I made it, I'm alive, nothing happened to me, I'm good. Okay, so now what? What do I need to get back home? Like things change a little bit. I'm a little bit weaker. Things a little bit different after the stroke. What do I need to get back home? So at that level, it's a lot of looking for the goals. It's a lot of finding what's gonna help the patient personally get back home. This is a place where you spend a lot of time assessing again, but to know to mimic to see what home looks like. You want to make sure that the person can go back home as much as possible, as close as possible as they were before they went to acute care. So you have to take your time to really see this. And one question that I always ask the clients or the patients is, describe to me your best day. What's a best day for you? Because through this, you learn their values, what's important for them, how do they see, how they're going to see rehab, bring them, what will rehab help them go back to. So people will tell me, oh, I just love to be in my kitchen, cook for my family for holidays. This is my happy place. People will be like, oh, I love when I'm at work and I'm like delegating stuff and I'm like super busy and I'm like I have value through my job. I really like to be in my backyard on my own, nobody with me, just in my backyard with the flowers. Or somebody will say, "Oh, I like to be on the beach with my partner and hear the waves." Like you really get to understand their value, what's important for them, and what they want to get back to. So I encourage you to ask that question because it's going to tailor everything in your rehab after that. I have to say also here, less paper and pen. We're moving away from paper and pen. In inpatient rehab, we do a lot more functional tasks. We're really trying to get to what the patient needs right now and how they live their lives. There's a lot of different therapies that I talked about before. Sheila McDonald, Deirdre Spear, they're all doing great therapy approach to help people in inpatient rehab get back to their lives. So this is where you will find the bulk of the team, the CDA, SLPA, and the SLP. This is where they're the most, in my opinion. And this is where that team is so crucial. So again, the SLPs is going to continue to look at what are the goals. And again, I am doing a whole webinars on goals this summer because it's a lot. There's a lot of different goals that you have to look for, and it's really going to drive your therapy. So I hope you can join me in that one as well. So really try to look at what's important for the patient. We design the therapy based on function. What do they need to return to be able to do? And then lots of family education because what happened to the patient with you happened to the family. The family also changed their lives to support the patient in rehab. So include the family in the therapy, include the family in the education. For and basically for CDAs and SLPAs, we're co-leading. We're co-leading here. And this is a place where we can do a lot of group therapy to see more people together. We develop a lot of materials specific to each patient. We do some memory books. We develop some homework. We do, again, meal observation. Sometimes we also look at hearing screenings. So this is where our role are very adjunct. I'll give you an example when I worked with a CDA in rehab that I loved our teamwork. This is where I was doing active rehab, so see the patient every day. On Monday, start the assessment, figure out the goal, give it to the CDA. The CDA starts working on it on Tuesday. Wednesday, I continue the assessment, find another goal that the patient needs to work on, give it to the CDA, they keep working on it. And then I finish my assessment on Friday. And then I had time to write my report while the CDA was already starting to do some therapy. So we didn't skip a beat with making sure that the patient would always get some type of therapy. Either I finished my assessment, I do started therapy. But together, we work so well together. This is where there's a lot of creativity in inpatient rehab. You can work with other team members, OTs, dietitians, social work to really augment your therapy. But really, the CDA and the SLP team, I don't know how people work in rehab without a CDA. I've never done it. I don't know how people do it. It is essential to the team, and I think it helps it helps the patient outcome to have more people in our group. Now, sometimes you go straight from acute care to outpatient rehab, or sometimes you go from acute care to inpatient rehab to outpatient. So you've done a little bit of work, you're getting better, you're good, now you can go home, but there's still some fine tuning that we want to do. And it's okay for you to come a couple times a week. So this is what outpatient rehab is. And again, there's a lot of different focus in outpatient. There's a stroke, there's neuro, there's a breathing, there's RESP. So depending on which hospitals and where you are in the world, there may be different needs. And so this is where you fine tune the skills and really you make sure that they transfer to real life. You want them to really go towards, okay, now you're home. Is it working? This is the type where you can, between, you come in session, okay, are you able to read the newspaper? Come back and tell me. Are you able to read the recipes? If not, come back and tell me. We're going to be able to look at that. Have you gone back to work already? What are the skills you need to work? Let's come and practice. So they have a little bit of practice at home. They come back, we fine tune. They go try it again. We come back, we fine tune. It's great because the patient now sees really the value of therapy, and they really our role is really to tailor the therapy to their lives, right? So that's the role of that. We still remediate, but we do a lot of compensation if there's residual problems, residual skills that are not back to normal or back to baseline. So this is where we become more creative in making sure that the client can return to some functions with compensation. Functional focus, there's no point doing paper and pen really. It's more focused on tell me what you have difficulty at home, let's talk about it and try it again. Yeah, just like I said, go home and tell me what works and what doesn't. That's exactly what outpatient is. So I stay creative here because those are suggestions that people have told me. I've done outpatient rehab too, but a little bit less than all the other areas. And this is where the SLPs refine or compensate for the remaining deficits to make sure that they can live independently at home. Independently means that they know how to set up the environment to continue to function, or that they know what strategies to use to be able to do the function. And so it's really where we want the patient and the family to monitor their skills. And this is where we really tailor again the home programming. And the CDAs do the same thing with us, the CDAs, the SLPAs, they really reinforce the techniques that we see in the session. And a great model that I saw in a hospital once is how the CDA was the person tracking in between the sessions to make sure that the person was applying the strategies, calling the client at home. Did you go through your checklist? Is it working? Okay, if not, we'll redo another one the next time you come in. So it was great continuity to make sure that whatever was learned as inpatient or outpatient sessions really got ingrained in it, like a lot of accountability, right? And so that was one thing that happened a lot. There could be still a lot of home programs or homework that the CDA can do, but at this level, the CDA can do as much refining and compensating as the SLP. So it's a great teamwork. Okay, I'm going to move on to long-term care. I'm just going to check the time quickly. Okay, good time. Long-term care, so it can be called different things in different places in the world, but really it's where when you're elderly and you're stable and you don't have any ongoing acute medical issues, but you need support. You can no longer be at home alone and you will need support, sometimes mentally, sometimes physically. And so long-term care, LTC, nursing home, home for the old, I think is that they call it. I'm not sure, but this is the setting. This is the population that we are providing care for. Depending on the funding model of your healthcare, it's going to look very differently. Some places will have the therapist in the home, and some places will have somebody from a community agency come in the homes and provide the care. But this is where we want them to maintain their skills. This is where we want them to have to really to live well, and to maintain quality of life as much as possible, maintain independence. It's a very strong word, dignity, but they need a lot of support in so many other areas. So if in your capacity, you can bring the independence a little bit more, brilliant. Bring the independence in terms of eating, bring them closer to a regular diet. If you can accommodate their diet so they don't have to worry about eating anymore. If you can make sure that their communication supports are such that they can independently communicate with the staff. It's great. Sometimes it's a lot of education also to support the staff working with them. So you'll work in partnership with the nurses there, because whatever you do to support them, they can follow up while you're not there. And the family is also a great ally in these situations as well. Often when you go do assessment in long-term care facilities, it's always around mealtime. And this is a very typical, I love nursing home because they really try to recreate the dining room area, look at opportunities to remain social. And so this is usually where you go and do assessment. You sit down in the dining room with the client under the patient, and then you do therapy there, or you do a swallowing assessment there. So it's a very sacred time where everybody comes together. So it's really nice when I go in nursing homes and I sit with everybody, and everybody kind of knows each other and checks what everybody else is eating. It's kind of nice. So this is the setting of long-term care, and this is our role. Now, there's not a lot where I am in Ontario, Canada, there's not a lot of CDAs and SLPAs that work in the community or in long-term care in that role. But really, it is the same role to support the SLP. Whatever the SLP is doing, they support the role, so they can. I'm just going to focus on the CDA role and the SLPA role here. They can observe at mealtime, see if there's anything that we need to do in terms of their diet texture or their meal experience. They can, I didn't talk about this before, I should have, but reinforce oral care routine. Oral care is a big deal in our field. They can really reinforce that. And if they are participating in some group activities, sometimes to augment quality of life, and be well, they can do a lot of reminiscence tool or reminiscence therapy when we talk about the past, often implemented on dementia based units. Hearing screenings. We know that in our aging population, hearing loss is prevalent. So it's another area where the CDAs and SLPAs do have the knowledge and specialty to take care of hearing aids and to do hearing screenings and to troubleshoot hearing aids. So it would be great to have a go-to person to do that. So that's another role that's really, they can have this role also in outpatient and in inpatient rehab, but I think there would be a great role, especially in a nursing home, right? Labeling, making sure everybody has their own way to be able to hear and participate in other therapies, troubleshoot with the family, check the hearing if the hearing is questionable. So that would be a good one too. In long-term care facilities, SLPs really work with the dietary team as well to look at the food, because it's a little bit different than in hospitals. And so you always connect with the dietitian when you go to a long-term care facility. Home care. So home care can be called so many different things in different provinces. And really in Ontario, it's been called 5 different things in the last 5 years. So it keeps changing, but it's still the same thing. It's an agency in the community. It's like if you're the therapist, the clinician, you belong to this agency and you go to people's home to help them out, usually funded by the government, typically. And you go follow up on the care. It could be they could self-refer, or sometimes it could be recommended by the previous teams. So for example, if you're in acute care and you saw that they're going to go home, they don't need rehab, but they just need somebody to check in, then maybe the acute care SLP has requested for a home care SLP to follow up at home. Or it could be the inpatient rehab SLP or the outpatient rehab SLP that said, we still need to continue to be in your home when our services are done. And so usually we meet them at home, and this is great. Everything is practical. You're in their home. You see what they eat. It's their food. It's their cutlery. It's their environment. It's their kitchen table. You see the whole setup, so you can really tailor your care to their home. So it's the best care basically when you're at home. And so I have not yet seen CDAs in that area in Ontario, but if it happens in other settings, this is amazing, because the CDAs and SLPAs extend the world of speech pathology and make it accessible for more people. So it's not just assist the speech pathologists, they expand the reach when we have a team that works together. And so if you have access to a CDA and SLPA in home care, amazing. So again, it's about it could be supporting the caregivers, the family, and the other caregivers. It could be also having some check-ins to see how they're doing. If it's not about swallowing and it's more about communication or cognitive communication, this is where the checklist and the check-ins on the phone and the visits to see how they're doing and with their own little home program could be great. But I've yet seen it, but I'm putting it out there. I'm putting it in the universe because we can have a role, as you can see. Just going to check the time quickly. Okay, good times. The other type of care that people can be, so sometimes people can go to long-term care, as we saw, like a nursing home, where really you are stable and you need some help, often mentally or physical, to live. And it is the way the system here in Ontario separates it, as if you need a certain amount of care, you can be to a long-term care facility. But if your care needs are high, you need to go to a place where they can help you with your complex care. And your complex care is continuous, hence complex continuing care, CCC. So this will differentiate the patients that have a trach, cannot speak, have a feeding tube, have complex needs that need a more specialized team. Often in these areas, you'll have a respiratory therapist because we have patients, or I say a trach, but it could also be vented through the trach, so long-term vents. So we need a specialized team to help support their breathing. And so this is a different type of care as well, but it's also a place a little bit like long-term care, but a little bit more specialized. And this is where I added AAC in the acronym. AAC, for the people who don't know, it's Augmentative Alternative Communication. This is a field of speech pathology that so niche, so important, such experts when you become an AC expert. It's basically a team, and typically the AAC team is an occupational therapist looking at how you move your body, a speech pathologist, a CDA always, and a technologist. They are a team that looks at how can we support your communication if you're not able to speak, if you're not able to use your hands, or if you're not able to move your body to be able to access speech. So they will help you access either writing aids or communication through devices. So just like on this picture here, you see a lady with a trach, maybe not able to speak, maybe have other disabilities, and is using a device to communicate. And so this highly specialized team, AAC, will take care of this whole phenomenon. I am in awe of the team in AAC. Whenever I connect with them or consult with them for clients that I see, the CDA runs the show. Really, it's that person that trains the client, trains the family, comes to the home, make sure that all the caregivers knows what's going on, The SLP is there for the assessment, the occupational therapy is there for the assessment, the technologist is there because we need to make sure that the machine works. But the person really making it happen is the CDA. I rely on the CDA whenever I do these meetings and whenever I do these troubleshooting with the devices. So this is a world where it's very niche, but so needed. When you're become an AAC expert, you have such an expertise that people need. So I put it here. It would deserve its own page and its own webinar, but I this is one area that I'm still learning, so I can't talk too much about it at the moment. But I know that for our clients, our patients in the CCC area, they often are benefiting from the AAC clinic. This is an area where we want to celebrate life, just like in long-term care. We want to make sure that you are supported and you have quality of life. And sometimes we got to find different ways to bring the quality of life to you and think outside the box because of some of the patients' disabilities. They may not be able to talk. They may not be able to move their body. So we want to bring things to them to experience the world, to experience to have quality of life. And so often here, I talk about the wake up program here because when I was in CCC, we did that a lot. So for patients who could not communicate or were minimally responsive, we did bring the world to them. We called it the Wake Up Program. It was led by the CDA and the SLP, mostly the CDA, to bring the world to them. Every week it was a different theme, and we brought the senses. So we made sure there's something to smell, there's something to touch, there's something to hear, and all the senses. And the CDA was key at developing all the material and bringing it to the room and working with the client and the patient, and also observing and taking data to see how the patient reacted. Are they reacting more to hearing? Are they reacting more to touch? And so to log all this information, we often had the CDA also help us with that. So it's a different role in CCC. So it's a lot to support communication. Not often swallowing. Often the patients at this level cannot eat, or it's been determined already with a feeding tube. So we support everything else. Oral care is a big thing that we try to do as well. We both have a big role for that. Hearing aids and troubleshooting hearing aids is another thing that we do. And we monitor communication. We want to make sure that patients can talk about things beyond their care. Often the nurses are looking at the devices so patients can talk about if they need suctioning, if they need to be changed, if they need to be, if they need reposition in their bed. But for me, I think it's great when patients can talk about other things because it's not just about our care and our everyday needs, but it's about imagining, creating, playing, socializing, connecting. So when I can set up somebody to still be able to do this at this level, it's magical. And then there's some of our colleagues who are generalists, meaning they work in areas where they do it all. Jack of all trades. They have to be the anchor in the storm. Everybody comes at them with everything. Often it's in rural areas, in smaller towns, where they just see everyone. And so it can be hard. And really, it can be hard to be to give equal care to everybody. And then you can't really do it alone. You really need in these areas, you have to rely on the funding. You have to rely on making sure that everybody has a little bit of time, no matter what their emergency or their severity is. So often this time would be dictated by time. So it's not that, oh, I see everybody and I'm going to work with adults because they have more needs, or I'm going to work with kids because they have more needs. No. Monday, Tuesday, I'm with kids. Wednesday afternoon, I'm with adults. Friday afternoon, I'm doing outpatient. So it's just, and this is dictated by funding, often out of our control. We have an input, but it's out of our control, depending on what area in what region you work at. Generalists also in countries that don't, maybe third world countries, if I can say, not first world countries, where there's a main hospital and everybody goes to the main hospital to receive care. So often the SLPs in the area, the CDAs and the SLPAs in this area know a lot. I've find ways to use their material for different people, have an office that can see different people. So they can become really creative. And so it's really nice when they can really pivot really quickly. If you're in this area, you do a lot. Often, it's really you're trying to balance all the demands and you try to identify the equity gaps, but it's often in conjunction with your administrator to know where to go. And again, the SLPA and CDA sometimes can help in supporting some of the things in the clinic. So if it's a clinic that's very busy, the CDA and the SLP can help with the scheduling. They can help between sessions. They can help call back families. They can help just support the everyday work that happens in that clinic, in the speech pathology clinic. Sometimes they can send home programs. They can, like I said, they can prep the room for different sessions. If you see a baby at some point and then you switch and you just see an adult, if there's anything that needs to be in a room. So it's really good team when this happens together. I worked in one area very quickly where this had to happen and it was great. We had synchronicity happening together and it was great teamwork and it made the day go so much faster. And always in every area, we know that data collection, CDs and CPAs can also help support us with data collection. I'll move on quickly to private practice. Just want to check the time. Good time. I'll move on quickly to private practice. This I'm always careful with private practice because people pay out of pocket. And personally, I always feel like I need to produce more, I have to do more. There needs to be a huge impact because people are paying. But also because people are paying, sometimes clients can be demanding. So for example, I'll say they want speech therapy. They want us to do a very, very, very quick assessment because they want to get to the therapy. But it is in our clinical competencies, we have to assess. We cannot see somebody without doing the proper assessment. So sometimes we need to really showcase our role and say, I'm happy to work with you, but first I need to dedicate time to assessment. I can't skip it. And sometimes it's just a discussion sometimes that needs to happen because they pay out of pocket, sometimes they want to skip it. So something to think about sometimes. You really have to define why you're doing those things. And I find that because people pay out of pocket, sometimes we want to be very tailored to the specific need that they want, but also be open to what else could be happening. So a parent may want me to just work on Arctic, just work on the pronunciation. But as a speech pathologist, I assess, I see other impairments. It's my role to let them know and see if they're okay to work with it as well. And what I like with private practice is it's and I put a computer here because a lot of it is virtual now. This is what a lot of private practice are like. It's virtual, but you're still in people's home. You can do it everywhere, anytime. I've done therapies at 8 o'clock at night and 7 o'clock in the morning. And so you can really tailor you stay flexible, but also you tailor your service to the needs and the availability of the patient. So you can be very creative with that. Very transparent. I find that when I work in hospitals, the hospital has a lot of legislation that helps you follow the law. There's things you have to do on your chart. There's things you have to do when the patient is with you that you have to do because this is the culture of the hospital and it's rooted in legislation. Sometimes in private practice, you are the legislator. You have to make sure that you follow the rules. So you got to be very transparent. You got to say everything. You got to make sure that you go in the order that you're supposed to. So it's something that I have to be aware of when I do private practice. And again, here in private practice, I would say the CDAs are such a SLPA and SLPAs and CDAs we're like a team. It's allied. I'll give you an example of an activity that I did with a client who had a motor vehicle accident and had a lot of cognitive communication problems. So it was hard to, for those who are not familiar with the field, it was hard to think. It was hard to self-evaluate your performance. It was hard to organize yourself. So my therapy, the way we work together with the CDA, with its client, is that she needed systems. It was hard for her to think about what to do and organize herself. So with her in my sessions, I would create systems and then she would apply those systems with the CDA. So she could not go through her mail. Like managing mail was too much for her. So her mail was pile, pile, pile. So we devised a checklist that when you get your mail, there's some that is FYI, good to know. Some is action required, and some is you need to file. And some is just information for future. And so we did a checklist for her to triage her mail this way. And the CDA came and sat down with her on these sessions and watch her apply the strategies and think through all the different steps so she can at least look at her mail every week or every month or every 2 weeks. So that was one system. Another system was grocery shopping. We said, okay, you're gonna say what meals you want first, what you need, what you have at home, and what you need. And then the CDA sometimes would look and make sure that all these things were filled out and do some community outings too to see how she would be at the grocery store. So brilliant. It was such teamwork. Love it. At that level and private practice, I love it. It's just a great way to extend your role. And also because the CDA and the SLP have different life and work experience, it's two heads together working for this client. So that's the other good benefit of having somebody else in your team. I'll talk quickly about pediatric care. This is an area that I'm starting to explore myself. I'm now in part of a private practice and doing a lot more with kids on the spectrum and Arctic and fluency. And so I'm starting to understand what it is to work in that environment and to work with assistants. And it's really, pediatric care, you really know that you're building people for the future. It's not, they're not at the end of their lives where they're trying to compensate. You're not trying to compensate at this level. Your role is to see, okay, they need to be able to build the skills for the future. So it's a very different way of looking at your role. And really the family, the parents, or your partners in this, they will carry on at home or tell you more about what's going on at home. So I really like the partnership with the parent. And at this level, the CDAs and SLPAs with SLPs work together. Again, the SLP will often do the diagnosis and the assessments, and the CDAs will deliver the goal-based therapy. And we'll create some home programs, we'll collect some data, we'll also customize some materials so it's tailored to the client. It's such a good teamwork when everybody's together. And so those are the different settings that I wanted to talk to you about. I really wanted you to understand that we have a different angle and perspective of who we are in a team that looks after different types of patients in different settings. And that it's important to realize that because I've seen many times SLPs that were seasoned in acute care and then switched to go to rehab, and they found the pace so slow. They said, what are we doing? And they just couldn't find their groove in rehab, whereas rehab, it's not acute. It's not about people are stable. I remember that that colleague was saying, everybody's good here. What are we doing? She had a hard time understanding that it's not about stability. It's not about life or death. It's about how am I going to get back home? And so now today she's great, but I remember having this discussion with her. And it was the opposite for me when I went from rehab to acute. Things were so fast. I was lost. The thing that was changing every day, I was panicking. I was missing things. But then when I understood that this is my only job is to figure out, who is the sickest and what do I have to go to, then I understood what my job is. It's not about trying to schedule a patient to talk to them tomorrow. It's about doing it now. And so I find that if you can maneuver the system, if you understand the system, it helps you in your job. One more thing that I will say here before I open up to questions is it's really important to know the whole system, even though you work, let's say, in rehab. It's important for you to know what happens in acute care and what happens after, because as a healthcare worker, you can guide the patient and let them know what's coming next. Sometimes when I'm my primary job right now is to work in acute, and I guide people through the system. So I let the clients know. So now when you'll be stable, you'll be applying for inpatient rehab, you'll wait, you'll have to make some choices. The social worker will speak to you, then you'll go to rehab at this level, then they'll see what you're going to be. So it really helps the families understand what's coming next. And it helps you to understand where they came from. So to understand the whole continuum of healthcare is so valuable to you to know how you're going to do your job, but also you're going to be a different person for your client and for your patient because you come with information. You come with something that will feel that you'll be a person that answers all their questions and keeps them at ease in a system that they don't know. And they came with something that was really unstable or frightening. You give them a bit of peace, right? And so sometimes it's good to know the system that you work in. So what's next for you? I'm saying I always put the butterflies back. The butterflies back because I really want you to understand now that you have this information. What are you going to do about it? Are you going to continue to learn about your healthcare system? Are you going to try to volunteer in different settings? Are you going to try to talk to your fellow students and know more about the setting they're in to understand the healthcare system? I really encourage you to do that. That's really what I'm hoping that this talk did for you. And then I also want to let you know about what's next for me. Differently with Soul. Really, I did it last summer and I'm doing it again this summer. This is the first webinar of the series. I would like to spend summers sharing information that I've learned. I'm really here to pay it forward. I've had so much help. I've noticed so many things. I've got so much feedback that I'm like, why am I keeping it for myself? I am here to give it out. See if that helps you with your job, your placement, your interview, or applying to speech therapy to know more about what we can do. Today, we did our clinical roles. In June, we'll be doing documentation because documentation is part of our job and it differs in different settings and for what purpose. Then we'll talk about setting SLP goals. And it you can do good job when you have the right goals. So I want to discuss what it is to set goals in our field and what it means to set goals and the sub goals. So I want to dedicate some time to really bring a different perspective to people who want to hear. And a big one, managing conflict and difficult conversation in the clinical settings. I don't know if I have enough time in an hour to talk about all that I want to say, but I really want to start the conversation this summer with you. It's tied to psychological safety. It's tied to culture dynamics in the workplace. It's tied to everything else than your skills as an SLP that makes you like your job. And so maybe I should, in hindsight, maybe I should have started with this talk, but I think I really want to harness you with the tools or the aha moments that I've had so far that help me tackle any conversation. Anybody that knows me knows that I don't have a problem with difficult conversation at work and outside of work because often it's just a miscommunication that we need to tackle. But how to tackle it in a team where you're a new grad, in a team where there's like a hierarchy of power, how to tackle it to also support your client. So please join me this summer, register the same way you registered for this one, and we'll continue the conversation. I just want to, before we conclude, do we have time? I just want to talk about this one here. So when we understand our roles deeply and collaborate intentionally, we create a bridge between science and soul, function and joy. I want us to go beyond surviving in each setting. I want us to thrive, to lead, to inspire, but with clarity of what we're supposed to do and compassion. So I hope that we met the webinar goals today. I want to open up the floor for questions if there's any questions. Thank you for great presentation. All those industries you mentioned, are they covered in the hands-on portion of SLP master program? Great question. So you will be learning about the practically the therapy when you do your master's, when you go to school. We want you to be able to develop those skills in this specialty, and you're going to go practice it in different settings. And so we do in masters or at the college level, you will talk about these different settings, but where you'll be able to go and practice those skills tangibly, functionally, is when you go to placements or internships, however you call it, externship, however you call it around the world. But this is where you will have to be flexible in how you're going to apply it in different areas. So seeing a stroke patient in acute care, seeing a stroke patient in rehab, seeing a stroke patient at home, you will use the same tools. They still have aphasia, but in different settings, at different levels, different severity. This is where this is why we need placements, is to try all those things. So this is a great question. Good question. Thank you. And so I want to thank you so much for launching with me the webinar series of the summer. I hope to see you in the next one, but really let me know how I can support. I find that our role is not very well understood in healthcare. We're always the smallest team. Physio, OT have like 20 million people in there and assistants galore. And I find that when people find out what we can do, then they understand the value of our work. And so the more you feel at ease and you expand your role in your setting, the more awareness there is of our profession. So thank you for you guys to take some time in your evening to want to learn more, to want to, the word I'm looking for is distinguish yourself from the other students or the clinicians, to know a bit more and to entertain a new perspective. So thank you so much. I will stop the webinar right now, and I'm going to wish you a good evening. Bye for now.